Non-invasive ventilation for the nurses today. I think most of you will be working in some ICUs, and in all ICUs right now, some patients will sometime receive a non-invasive ventilation. What is non-invasive ventilation? When people it started somewhere in the early 50s when people had some polio epidemic in the Denmark, and then they started getting ventilators. And since then, ventilation has been a machine which has been used often in the ICU to support the respiratory system of any patient. That might be due to hypoxemia, that the patient has got low oxygen and cannot maintain with lots of oxygen supplementation. It can be because of hypercapnia, that the patient is developing high carbon dioxide and it is not being able to be corrected by nebulizers and other medications, or sometimes just to reduce the work of breathing. That is, the patient is panting too much. Maybe the oxygen and carbon dioxide at that point of time is fine, but there might be other causes like severe metabolic acidosis, the panting too much. To reduce the work of breathing, the patient is put onto a ventilation. And all these were basically invasive ventilations. That is, an endotracheal tube was put in, and it was connected to a machine which would deliver some tidal volumes with each breath. The advantage was that the doctor was in, or the doctor or the nurses were in full control, and the patient's breaths were controlled by machine and delivered by machine. The disadvantage was that we were breaching an anatomical barrier, that is the vocal cords, which normally they close whenever we swallow, etc., and does not allow the any foreign material to enter our susceptible tracheal and bronchial tract. But if I put in a tube there, the vocal cord would be always open, and there is a good chance of foreign materials entering and causing infections, inflammation, etc. And also the patient could not speak or talk while the patient endotracheal tube was in place, and endotracheal tube itself was basically a very uncomfortable proposition. So people started thinking about delivering the same thing by a mask, where the patient endotracheal tube, the vocal cord, etc., will be left alone. They can talk, they can at times can remove and eat food orally, and their anatomic barrier against infections is intact, but the patient is ventilated. So the NIV leads to reduction of inspiratory muscle work because they are giving a support from outside, avoidance of respiratory muscle fatigue, and NIV also leads to prompt improvements in gas exchange. How I'll discuss later in the subsequent slides. So the principle was that ventilate before intubation. I don't need an intubation basically to ventilate if I need to ventilate a patient. If intubated, extubate early, that is, take off the ventilator and put the patient on an NIV if possible in a planned way. If extubated, prevent re-intubation. That is, after extubation from a conventional ventilation, prevent re-intubation by putting in a non-invasive ventilation. Indications of non-invasive ventilation. Basically, non-invasive ventilation initially was used mostly as a CPAP machine in patients with obstructive sleep apnea, and there it was given attached to the nose, and so that the patient's airway remained intact during sleep, and there was less snoring and less obstructive sleep apnea. But now it is given over a wide gamut of diseases, like prevention of hypercapnia and COPD exacerbation, or hypercapnia and COPD exacerbation. That is, you can see this is a very good evidence for this. It has been tried, studied, and it has been found to be an effective treatment. Cardiogenic pulmonary edema, that is when there is patient has got a left ventricular failure and there is pulmonary edema. While the drugs are working in the initial stage, you might require a non-invasive ventilation. Acute asthma exacerbation has not been proven to be beneficial, but there are studies to show that it may be effective. Immunocompromised people, where we do not want the patient requires a ventilatory support and we don't want to put in an endotracheal intubation, as the risk of intubation-related infection is very high. Next, post-operative patients sometimes, palliative care, that we have decided the patient has got some end-stage disease, suppose a end-stage cancer or maybe motor neuron disease, where we do not want the patient to be intubated, let the patient live peacefully for some time in comfort, and there we can use non-invasive ventilation. Next, trauma patients, where there is a flail chest, the patient is too painful for the patient to take an inspiration. And so what the patient does, they go into a respiratory failure. They don't inspire much because they've got chest pain on inspiration, and that causes respiratory failure. Here, a non-invasive ventilation may help. And then post-extubation high-risk patients, prophylaxis, that some patients, if you think that patient after extubation may require again a reintubation. You can try a planned way that you take off the patient of the ventilation and put on a non-invasive ventilation. Next is post-extubation respiratory failure. That is not a very good indication that you've extubated and suddenly the patient goes into another respiratory failure. Then it might better that you intubate the patients, and meaning in hypercapnic patients, etc. Indication for starting NIV. When a patient, how to know that this patient is right now going to require a non-invasive ventilation? Patient inclusion criteria, patient cooperation, that is, the patient has to be cooperative. He has to understand what we are doing to him or her, and then initially it might be slightly uncomfortable as you are putting a high pressure mask on the patient's nose and mouth, and then you slowly, patient gets used to that. So cooperative patient, if the patient has got dyspnea, moderate to severe, but of short of respiratory failure, tachypnea more than 24 breaths per minute, increased work of breathing, accessory muscle use, part sleep breathing, hypercapnic respiratory acidosis, range being 7.1 to 7.35, and hypoxemia, PaO2, FiO2. That is how we actually calculate. That is how much FiO2 you are giving, and with that, how much PaO2 the blood gas is showing. Nowadays, we have also got an SpO2 by FiO2 ratio, and if that is less than 200, that is just a value, but you can use even in less hypoxemic patients. But if you're not being able to maintain with oxygenation, whatever the way you are giving, then you can try a non-invasive ventilation. There are some also contraindications to non-invasive ventilation. So, what are the contraindications to non-invasive ventilation? If there is absolute contraindications are respiratory arrest or unstable cardiorespiratory status. If you feel the patient has got a cardiac arrest, respiratory arrest instantly, and you want to resuscitate the patient, that is not a good patient for non-invasive ventilation. Next, as I said, the non-invasive ventilation requires some cooperation from the patient. That you will be saying that the mask could be there, patient has to be patient, so that the mask works. There will be some discomfort, but the patient will understand and tolerate that these are necessary. But if the patient is too anxious, too restless, always trying to take off the mask, then that is not a good for non-invasive ventilation. Next, the patient who cannot protect the airway. Say patient post CBA or in too much of sedation, unconscious state, where you feel that the patient cannot cough out the sputum. And here, because contrary to invasive ventilation, there is no airway protection in non-invasive ventilation. The tube is not there, so anything or everything, any vomitus, any big blob of saliva, it straight goes into the airway. So that should not be used for these are the patients who are not suitable for NIV. Trauma or burn involving the face, because many of the masks are oronasal masks which involve the face. If there is a lot of trauma or burn, then you should not use such a mask. Facial, esophageal or gastric surgery, upper GI surgery, particularly esophageal surgery, initial first 48 hours, if you give high pressure through this non-invasive ventilation, that may cause a blowout of the surgery. Apnea, poor respiratory drive, the patient does not take a breath at all. In that case, you are also not supposed to use non-invasive ventilation because that will be unstable or uncertain. Next is your reduced consciousness. I've already discussed if the patient cannot maintain the airway, and air leak syndrome. Somehow the face is like that the mask is not exactly fitting. No mask is fitting. There is a lot of leak. These are patients who cannot undergo non-invasive ventilation. Next, there are some also soft contraindications where you should think of something else, try to avoid non-invasive ventilation. Extreme anxiety, as I've told you, patient who is continuously telling do something or take it off, mask I want to talk, etc. That's not a good thing. We do not want to use heavy sedation in patients with NIV. Morbid obesity, where basically the NIV, the amount of pressure we're giving may be inadequate to inflate the chest wall. Copious secretions. Every 5 minutes, the patient wants to cough out some amount of sputum. So here, if there is an NIV, the NIV has to be disconnected, again put in. So if this happens every 10 minutes, 15 minutes, it becomes untenable. Need for continuous or nearly continuous ventilator assist. Some patients are so distressed that you cannot take off a non-invasive even for a few minutes. So that is also not a good candidate for NIV, non-invasive ventilation. Lack of respiratory drive. And if after putting in an NIV, the patient's condition deteriorates. NIV failure rate. Basically, you can see most of the NIVs, they fail early. That is after the first hour. They don't fail instantly. You give an NIV, the patient initially feels some relief. And if the patient stays for 3-4 hours and is stable, then usually the patient tolerates it, unless there is something new happening to the patient, some new disease, the patient will tolerate. But this, from the first hour onwards to first few hours, This is the 70% of the NIVs, they fail at this period. So the lesson for the nurse is that whenever you feel that you put a patient on an NIV and you feel that the patient has stabilized a bit, don't leave the patient alone for next at least 3-4 hours. You keep an eye on the patient because the patient may go into a failure of NIV where there will be hypoxemia, increased carbon dioxide, unconsciousness, even unstable patients. So that should not happen, and you should keep an eye on the patient for first 3 hours. Next, nowadays, initially the NIV machines were very basic machines. They were called BiPAP machines, and they're very basic machines. There were no blender. You had to give the oxygen basically from a side port, a side tube. You had to give the oxygen, which would mix with the machine. And they had limited, some machines even had a limited work hours. That is, after 8 hours or 12 hours, you had to give the machine a break. So nowadays, as the indication for NIV has broadened, and many of the NIVs are being used as a sort of replacement for ventilators, invasive ventilators, they have become more robust, more powerful, and they can be run for hours and even days, and they are capable of delivering much higher pressure, and they have got oxygen blenders where you can actually choose, rather than by giving oxygen by side port, you can actually choose how much oxygen is mixing, and whether it's a 30% oxygen, 40% oxygen, you can mix. So essential machines for hospitals are pressure control machines, pressure capability of up to 30 centimeter of water. That's quite high for an NIV. Capable of supporting inspirated flows at least 6 liters per minute. Assist control and bi-level pressure support modes. Rate capability of at least 40 breaths per minute. Some of these patients are very tachypnic and even need to do that. Sensitive flow triggers. Disconnection alarm. That it should be loaded with a disconnection alarm. So whenever the tube is disconnected, because these are serious patients, they can fend for themselves. So should be warned about any disconnection. And also desirable are that short pressure rise time capability. That is when the people are panting very much, they want to take their breaths in, very short breaths, and for which you need a low rise time. Adjustable pressure rise time, adjustable inspiratory trigger, adjustable expiratory trigger, adjustable inspiratory-expiratory ratio in assist control mode. There are many nowadays newer ventilators who come with a pressure control ventilation, where not only the rate is maintained, minimal rate is maintained, backup rate is maintained, but also the amount of inspiration the patient can take is controlled by the machine. Next is temporary alarm cancellation facilities, internal battery with the power for at least 1 hour, acceptable control panel to cover lockout facilities, simple control devices, and LED, LCD displays. These are basically requirements for a machine which has to be used in an ICU. So these are called interfaces, the different masks which are used for NIV. This was initially this is the nasal mask. Sorry. This is the oronasal mask. This is the commonest mask which you use nowadays. This is the full face mask, where the whole face is covered by the mask, and this is called the helmet mask. All of them have got their advantages and disadvantages. Basically, pure nasal masks are not very good for patients with acute conditions in ICUs because they keep the mouth open. Many of these patients will be dyspneic and they keep their mouth open. If the mouth is open, you can see basically what happens, what pressure you're giving through the nose may come out through the mouth and be not effective. Oronasal mask is the commonest mask, as I've told you. The main problem is there is a pressure along the bridge of the nose, on the cheeks, etc., where when used for several days, they may cause ulceration, etc. Next is the full face mask is like this. The advantage is definitely it is covered well. There is less invasive, less chance of basically leaking, and the tidal volume is delivered well. But the thing is that patient may become claustrophobic. That whole nose, mask, etc. are covered, and that is effective. Next is that this is a helmet mask. This also can be used sometimes, but here also again the patient might have some claustrophobia. The main problem of these two interfaces is that if the patient requires to cough or vomit, then you need to take out the whole thing and allow the patient to cough and vomit. That is very important, and that might be cumbersome. In patient who is coughing too much of productive cough, it can be risky. So there is a general guideline. This is that what are the advantages, disadvantages. Some are less claustrophobic, more likely to have leaks in the acute setting. Some nasal pretension required, coughing and expectoration is easier. usual useful for prominent facial anomaly. So these all masks, they have got nasal mask, nasal mask, they have got their advantages, disadvantages. You'll have to choose as per the patient's profile. So if remember that if there is this BiPAP machines can be two tubed or single tube. That is from machine to the mask, there may be only one tube or two tubes. If there are two tubes, it's fine. One is for inspiration, another is for expiration. If it is a one tube, then remember that some leak has to be there in the mask. There should be usually there are one or two pores which can be opened up so that because it's a one tube, the amount of air which has been exhaled can be sent out of the machine. But if it is basically a double tube mask, double tube machine, then you need not bother. This is I'm telling you because you'll see sometimes there are two or three ports in a mask, and in a serious patients, the doctor or the nurse may decide to close all of them with micropores or adhesive plasters. So that's fine, but you need to keep at least one or two ports open. It can be fully closed. That is very important when you are, putting a patient on a non-invasive ventilation. Fitting the mask to be firm. There are several sizes actually. There is a scale at in the packet of the mask, and you can put the scale and find out what the size the patient requires. The actual size would help, and then it should be reasonably tightly put in. But remember, at least one finger should get by the side of the mask when it is tightly put easily. Unless it so happens it will be too tight and it's because ulcers. And if it is too lax, there are 2-3 fingers are going in, then also it is not effective. Prevention of pressure source, of course, as I told you, do not use too high a pressure, and sometimes people use flaps, basically to prevent ulcerations. So there are some issues actually. So when you are putting in the patient, if the patient is good enough to be interrupted, given intermittent NIV machine, so for every 3-4 hours, we can take off the machine for half an hour, 1 hour. There is no issue. The patient can be fed at that time. But if not, the patient might have to be put on an NG tube. NG tube because the patient cannot be disconnected from the NIV and cannot eat orally. The disadvantage of NG tube is that it is going to breach the connection, the tissue interface of the mask. If you go to the mask, see that there is this is the oronasal mask, and you are putting a tube somewhere here. So what happens by the side of the tube, there is excessive leak. So that is the issue there. That is, you need to remember. Next, if the patient has a long beard, this usually needs to be cut off before you put in an oronasal mask, because what I'm telling you, this too much of beard will prevent the mask from fitting properly to the face, and there will be lots of leak. Excessive secretion. If the patient has got excessive secretion in the form of cough, sputum, or oral secretions or vomiters, then the NIV is to be interrupted every 1 hour, half an hour to clean the patient. In that case, it is not a good choice for ventilator support. Similar thing with vomiting. If the patient vomits too much, it might be difficult to maintain a NIV. Next is claustrophobia with or without sedation. That is people particularly with large full face mask or helmet mask, they might be complaining of claustrophobia. Now the modes of NIV. As the ventilators, they have several types of modes. NIV, newer NIVs, they are coming with different types of modes. Basically, you can see that there is a spontaneous mode where the NIV supports. If the patient starts ventilated, anytime the NIV will support the patient for that ventilation. Anytime the patient takes an inspiration, the NIV comes in and puts in the pressure to support that inspiration. Next is ST mode. Remember here, the patient has to initiate in S mode, otherwise the ventilator does not support. If the patient takes 0 breaths, it's 0 breaths. And next is that your inspiratory time is also with the patient. If the patient wants to take short breaths, the machine will only give inspiration for maybe for 0.5 seconds each. If the patient wants to take a long deep breaths with every respiration, the NIV is going to support that long breath. Next, there is a spontaneous plus time mode. This is the most popular mode nowadays. That is, there is spontaneous mode that whenever the patient takes the breath, NIV supports that. But also there is a time mode. So that is, there is this also called a backup rate of ventilation. So suppose the patient, you have set the backup rate at 20. The patient right now is breathing at the rate of 26. Fine, if it is 26, all these 26 breaths would be supported by the machine. But if the patient decides to take breath right now, has become better and wants to take a breath of about 16 per minute. The NIV will, interfere and keep the minimal rate to at least 20 per minute. That is called spontaneously plus time. Plain time, it is basically it's like control. We don't discuss that. And there is a thing called a pressure control. Where the number of breaths or backup breaths are there, that is at least the patient has to take, say, 20 breaths. The amount of inspiratory pressure is fine. And also the inspiratory time is decided by the machine. Compared to a spontaneous or spontaneous with time mode, where if the patient takes a 0.5 second of inspiration or a 2 second of inspiration, all this during inspiration, the machine will support the patient. But in pressure control, basically, it will always say support you keep the inspiratory time at 1 second. So all breath, it would be 1 second of inspiratory time. If the patient wants to take a long breath, that's his headache. The patient is not going to support. If the patient wants to take a short breath, the patient will ensure the patient takes an inspiration for 1 second. So that is pressure controlled. And there is also a continuous positive area pressure, but there is no difference between inspiration and expiration. The flat pressure goes in the inspiratory time and the expiratory time. NIV setup, usually we tell a full face mask or oronasal mask. Initial pressure settings are EPAP of 3 to 5 and IPAP around 15 to 20. So up-titrated IPAP over 10 to 30 minutes to IPAP of 20 and up to 30. And IPAP should not exceed 30 or EPAP 8 without expert review. And IPAP is basically 10 or 5 above usual setting. And backup rate of 16 to 20 set appropriate inspiratory time. So as per the rate, if you're it's not a you cannot you put the patient on an control mode, pressure control mode, and an NIV, then you need to set up the inspiratory time. There is a thing called a rise time factor. So this is the maximum pressure delivered by the NIV, and this is the at the end of inspiration the baseline pressure. So from here to reach this place, it requires some time. The sharper it is, so it is the less is the rise time factor, and more delayed it is more the rise time factor. So what happens? A patient who is taking tachypneic, taking several breaths, the rise time factor should be short. It should be cut down to, it should rise like this, so that short inspiration, in instant you go to the maximum pressure and deliver the support. Had it been set to a slow like this slope, then what happens? The patient finishes his inspiration in this time, and after that the machine goes on delivering for some time, which causes a thing called a desynchrony. So that is the rise time factor you need to. On the other hand, if the patient is taking a leisurely breath, the patient has become better, but right now he wants to take breath at the rate of 20 and he wants a slow rise time factor. But here, if you have set them to a very short rise time factor, every time the patient wants to take a breath, it will feel that as if a jerk has come and the ventilator has put in a gush of air. NIV in different conditions, it is a treatment of choice in COPD, particularly acute exacerbation of COPD. Proven to save lives and shorten ICU stay. Suitable only for patients who are conscious and hemodynamically stable. And first few hours, they need to be watched carefully. NIV in cardiogenic pulmonary edema. CPAP is the treatment choice, but nowadays we know that BiPAP is equally good. You can give BiPAP too. Improve symptoms faster, decreases intubation rate, possibly decreases mortality in a subgroup, and indications are still fuzzy where you want to give, but we feel the word panting too much, and we have given anti-failure drugs, they have yet to set in. The patient is looking like axillary muscles working, etc., may go into a ventilation immediately. There you can put in an NIV, but do not give in patients who are basically were too ill or maybe had a cardiac arrest. There you don't use it. NIV in chest trauma, Gunduz et al. Conducted a prospective randomized trial of CPAP given by a face mask to spontaneously breathing patients, CPAP group number 25, compared with intermittent positive pressure ventilation with endotracheal intubation and patients with failed chest who required mechanical ventilation. So basically, this is avoiding intubation and ventilation of people with failed chest who cannot take a breath by themselves. Next, weaning from mechanical ventilation. What is the planned weaning? That I'm going to wean the patient, and after some time I feel that the patient right now not that fit to be only on oxygen or only on room air. There you might think that I might extubate the patient, not keep him in intubation anymore, but put in an NIV. This is a set of trials which has shown this, and you can see generally people will be favoring the non-invasive ventilation. And NIV for acute respiratory failure. So in
COPD patients, sorry, this is basically if you feel that the patient is on an NIV and too much of air is leaking, aperture 2 square is more than 29, that is the patient is ill sepsis wise. There is a lot of asynchrony that the patient is not matching with the NIV deliveries. There is copious secretion, like Glasgow Coma scale has gone below 11. Lack of compliance or tolerance, the patient can tolerate the NIV and the pH is dropping below 7.2 and respiratory rate is persistently 35, then you might think of putting the patient back to mechanical ventilation. Right now, there is a score called the Hackor score. It is available on the net, and you can use that to see whether the patient needs to go into ventilation. Next is NIV failure. NIV failure, where you need to intubate the patient. You have started on an NIV, but you feel right now I should not continue. Major criteria is that if there is a respiratory arrest, loss of consciousness with respiratory pauses, gasping for air, accessory muscles working, psychomotor agitation requiring sedation, heartless less than 50 beats per minute with loss of alertness, hemodynamic instability with systolic blood pressure less than 70. All these cases, you need to put the patient on invasive ventilation. And minor criteria, 2, that is, you take any one from the major criteria and pick up at least 2 from the minor criteria, where the respiratory rate is less than 35 breaths per minute, pH less than 7.3 and decrease from onset, that is worsened, PO2 less than 45 despite oxygen, and increase in encephalopathy or decreased level of consciousness. So that is our NIV for nurses. We have finished the delivery of the lecture, but if you have got any concerns and if you want to have some clarifications, you are free to ask me. I mean, mouth close to the mouthpiece of however you're talking. Hello?
Yes, sir. There is not any question in the chat box.
I can hear someone talking.
Yes.
There is one thing in the chat room. Is NIV and BiPAP the same? Someone has asked this.
Well, BiPAP is what you call a brand name. The Respironic company, when they initially started the NIV, they said that it was a bi-level positive airway pressure, so they call it BiPAP. NIV can be non-invasive ventilation, can be basically BiPAP or a CPAP machine. Sometimes basic machines which are CPAP, both are NIV, but some of them may be bi-level airway pressure. There is a different pressure for inspiration and expiration. So when you call it is a BiPAP machine. I think many of you are using NIVs in your ICUs. Many of you are working in ICUs. So if you face any day-to-day problem in regarding this NIV, then you can tell me or ask me. There's another chat. Let me see. When to use BiPAP versus CPAP. As I've told you, basically CPAP was initially used for patients who have got obstructive sleep apnea. This patient, they snore too much and there is basically the lax palate or the lax anteropharyngeal wall falling back, closing the airway, which would make them snore too much and they get sleepy in the morning, for which CPAP, nasal CPAP, there is a positive airway pressure was given through the nasal mask. It did not interfere with the mouth and is to give a positive airway pressure, which will keep the airway open. That was the CPAP. But right now, what happened that we are right now using it for a wider indication where we want to use it for also respiratory failures, several types of respiratory failures, considering it's a COPD or a neuromuscular disease or a chest trauma or not respiratory disease, but a pulmonary edema because of left ventricular failure, where we are using an advanced machine which has got bi-level positive airway pressure. That is, there is an IPAP which is given during the inspiration and there is an EPAP which is given during the exhalation.